a little different than at that time. I'm seeing this video after a long time. Then of course there was some dance program, and European doctors, they danced to the tune of Indian Bollywood, and this is on the top of the Eiffel Tower. So we had a exclusive program, and then of course there's some the whole day was talk. There was 2 days event, and about 20 to 30 international faculty, and then we had a 1 day so that people could attend. And this so I think this is long video. I'll just put the short. These are the lectures. Dr. He is from Shimla, Dr. Professor from here talking about, and then we had so many talks here. So this was the beginning, and then the TAVI talk, which I will talk today in the evening. And so this was the beginning, and then do we have Dr. Ashokan already connected? And can we play the video again? It's not playing. So we'll have a talk now. We start in between. We'll show this. He was already connected, Dr. Ashokan. If he is connected, then we can have a Zoom talk with Dr. Ashokan from Calicut. I think what we can do, by the time we are having 2 Zoom talks, what we can do, we can have a quick coffee break for this time, and because a lot of people are already here since 9 a.m., and then we'll come back in 20 minutes. So we can have a coffee break, and by the time we will connecting to the Zoom so that we can have next 2 talks. So coffee will be served just outside, just opposite that. So please, we can have a quick coffee and tea break at this time. Dr. Akshay and other people of your group and all these departmental people, they can go and have a coffee. Thank you. Is connected now?
Good morning.
Okay, sorry, I'm sorry because he's talking from Calicut. So we can have actually the talk of 10 minutes and then we'll have a coffee break. Dr. Ashokan is already there on the Zoom. Please connect to him and then stop this. Dr. Ashokan, can you hear me? Hello?
Hello?
Yeah,
can you hear me now?
Yeah, I can hear you very well, but we don't have the...
So it's happy to see you in the morning.
Yeah.
We love topics. Can I share my screen now? Is it visible?
Yeah, it's visible. And also welcome Dr. Tanuj Bhatia, who is also connected through the Zoom, he will be also part of the chairing session.
Yeah.
I can see your slides, and let me introduce your...
First of all, let me thank the organizer, Dr. Chinmaya, the organizer secretary and chairman, Dr. Vivek Gupta, for the invitation. And just I'm sharing a few interesting cases of the primary PCI. You see that as primary PCI, the earlier reperfusion therapy is a life-saving treatment with the STEMI, and primary PCI is the preferred method of reperfusion, no doubt in that. Why is so? Because primary PCI, the rate has risen from 20% about 2 decades to 80% now. Most of the reperfusions are by the primary PCI route. And one interesting thing is in-hospital mortality, STEMI in PCI, primary PCI is actually dropped to less than 4%. This 4% is about 6-7 years ago. Now is less than 4% the mortality after primary PCI. Why is so? Because the modern aggressive antiplatelet therapy and new stent designs have improved the immediate and long-term benefit. And I'll just show you one case, very interesting case. Is a post-EBG and done about 18 years ago, and presented with acute inferior and lateral infarction, STEMI. And this gentleman actually is on single antiplatelet and statin. And you can see that there is a SVG graft to this circumflex, and the sequential graft is occluded, and there is a high thrombus burden at the site. Now we successfully done the primary PTCA and put a stent, and not done any distal devices, embolization device, obviously, because it's a taut occlusion and the distal occlusion. And we're given the potent antiplatelet drugs here, ticagrelor, along with the aspirin and high dose of statin, and we discharge the patient. Unfortunately, patient stopped ticagrelor, and because of some minor procedure, presented with again after few days with HTMI in the same site, and this time the stent is occluded. Now is a very high risk in all aspects, and we have a lot of difficulty in HD engaging the vessel and traversing the devices across the stents to the distal part. We use the Guidezilla device, then a thrombus aspiration stent, and to put another stent at the distal part as far as the site of thrombus, because a high thrombus burden. And here, obviously, there is no role for glycoprotein to be a receptor antagonist, and no role for a distal protection device. We got a reasonable results. So this importance of continuing the potent antiplatelet drugs
May we
and
have Dr.
ticagrelor
Akshay to please
beyond,
chair this session?
say,
Dr. Akshay, please. Can
6
you be on
months,
the stage?
ideally for 1 year. This is a case 2, and this is straightforward, and in lateral valve infarction, STEMI. And here I just want to show that this patient done with a HDA IVUS cyst. You can see the thrombus burden here, and you can see that this TIMI zero flow initially, then it's got a taut occluded vessel, and we got a reasonable results. And we are done here the HD IVUS, and you can see the result is we optimized here, because you can see that there is no distal dissection and no proximal dissection. Landing zone is okay, and we got a fully expanded stent and good satisfactory MSA here. What I want to say here, if your device is available and you can see large thrombus burden, and you can use that imaging, and that's not a mandatory, but it's a class 2A indication nowadays. And this another case was the inferior infarction. We can see this ostial stenosis, tight lesion. You can see the high calcium burden at the proximal tight lesion with a high calcium. We don't know what is the reason, but we have a lot of difficulty in advancing in 1.5 balloon, and we have done rota here. So this is STEMI patients came with this 2:1 AV block with hypotension, with inferior infarction, HTMI, and you see the done angiogram, it showed a calcification. Now we have to use the rota and devices, and that also not sufficient, because there is a proximal tortuosity plus calcification. We have to use the Guidezilla device even for rota ablation, and subsequently also advance in the stent. And you can see the post-rota IVUS evaluation. You can see the concentric calcification, superficial calcification, more than 270 degree. And we can see the reverberation after robot ablation. And we cracked that arch of the calcium. And we got initially the MSA was 3.12. And this is stenting we have done. And this is the result post-stent. Again, he got a good reasonable result. With you can see that the stent is well expanded, and we got a MSA of say 7.3 square meter. So what I want to say is, sometimes the patient comes with even though with straightforward STEMI, but the lesion morphology may be different. And here is another patient, again the inferior infarction, with you can see that there is a heavy calcium at the ostial part, and you are dilated with 1.5, done the rota, and you can see that is a calcium nodule at the site, and subsequently there is a 270 degree of calcium. And here also in this case, we are done the case, we did this case with IVL, and you can see that this IVL crack in the lesion, and we stented, and we got a reasonably good results. So what you want to see is a primary PCI. Immediately you should refer the patient where there is availability of the facility, so 24 hours and 7 days in a week, and you should start the primary PCI as the earlier speaker said, as early as possible. If you can directly ship the patient to the cath lab, we can do the procedure within 60 minutes is ideal, or you should refer the patient within 120 minutes of to the place where there is a where there is facility for doing the PCI. Another concept is a transradial approach. Definitely is reduce the mortality and especially the associated complications and bleeding complication, and reduced even the short-term mortality as well as the long-term mortality in this case. And cardiac shock or hemodynamic compromise should not be considered as absolute contraindication. If there is a palpable pulse, we should go for the radial approach. And patient transferred to PCI capable center for primary PCI should bypass the emergency department and coronary care and intensive care unit and directly transfer to the cath lab if possible, so that we can do the procedure as early as possible. And this is the concept. If patients come into the first contact, and you should be able to diagnose within 10 minutes and should transfer the patient to the primary PCI strategy, and reperfusion you should cross the lesion within 90 minutes. And if directly come into the center with the PCI facility and bypassing the non-PCI center, and you should do the procedure within 60 minutes. So what is the recommendation? Patient working with a STEMI and the symptoms of onset more than 12 hours, if still there is a hemodynamic instability schema, we should proceed with the primary PCI. Is a class 1 indication. A routine primary PCI should be considered STEMI patient present even if late, even 12 to 48 hours after symptom of onset is a class 2A. Why? But if patient coming after 48 hours, if patient has no symptoms, there is no role for any PCI or angiogram. So radial access is a class 1 indication, and PCI with a test is a class 1 indication, and patient spontaneous coronary dissection, if there is no antigrade flow, is not indicated, but if there is a large area myocardiopathy and reduced antigrade flow, and you should intervene. Intravascular imaging should be considered to guide PCI. It's a class 2 indication. Again, the cost of the therapy should be considered. And routine thrombus aspiration is not recommended. So, if patient, the recent guideline patients coming with cardiogenic shock, immediate PCI of infrarelated artery is a class 1, and stage PCI of the non-culprit lesion later. A patient with STEMI and complete revascularization with culprit lesion, say at the index procedure, or can reassess the position, and within 45 days after the procedure can be done. So complete revascularization, that is non-culprit lesion, is recommended either during the index procedure or within 48 days. It is recommended that PCI non-infrarelated on angiogram severity, invasive epicardial assessment of non-culprit lesion of the infrarelated artery is not recommended during the index procedure. And what about the antiplatelet drugs? If patients coming with a STEMI and you have to continue DAPT, and you should continue for at least for 1 year, not like stable patient where you can stop even after 3 months and can continue on the single antiplatelet drugs. And this is a case, very interesting case, is the infeval fashion STEMI with a total proximal RCA. You can see that left main, there's a critical lesion and there's a proximal circumflex stenosis. What to do in this case? Anyway, we have to do the primary angioplasty of the culprit lesion, infrarelated lesion, RCA. And what about the left main, whether to do it same sitting or later? In this case, we did after 48 hours, patient is stable, and this is a result. So, let me conclude here. Currently, the management of patient STEMI is not only a mechanical restoration of the flow within the infrarelated artery, but it is also includes a system of early diagnosis, a rapid transfer to PCI capable center, and selection of optimal adjunctive pharmacotherapy, and finally, PCI procedure with the dedicated devices. And all these components are necessary for the eventual success of the treatment. Thank you.
Dr. Ashokan, you have really done a very good job in this talk, primary PCI. Primary PCI is actually very important because primary PCI means, of course, for the interested audience, we know that acute revascularization, that means angioplasty, stenting or without stenting or with thrombosuction or without thrombosuction, during the first golden 4 hours or 6 hours or 8 hours, depending upon the time of presentation. Normally, we try to do as early as possible. Normally, golden 1 hour is also important. Sometimes that is not achievable, but of course, angioplasty during heart attack, during acute MI. Uh, Ashokan, you can continue here and we can have a talk by Dr. Tanuj Bhatia immediately, and then we can have a quick discussion before we go for coffee break. So please stay back. Dr. Tanuj is online.
Yes, sir. Good morning, sir.
He will be, Dr. Tanuj Bhatia is basically from Dehradun, but he is at the moment Hyderabad. He could not come. End of the year, a lot of people are not able to travel and they are on the vacation mood. But he will be talking about thrombosuction. So thrombosuction is a methodology where we suck out the thrombus. So thrombosuction normally is not possible technically it's not required actually in a chronic stable angina where you have a cholesterol plaque. But this is a very important because I personally use thrombosuction in almost all, even if it is a moderate level of thrombus burden, because that helps in achieving a goal of TME3 flow. Because once you have a clot here, you put a stent, nothing will work. Angioplasty and stenting will be absolutely failure if you cannot suck out the thrombus which is there, which is the pathophysiology for the acute myocardial infarction. So Dr. Tanuj, in the next 10 minutes, we'll talk about the thrombosuction corporeality. Dr. Tanuj, please go ahead. Thank you.
Thank you so much, sir, for the invite, for letting me present on an online platform. And as you very rightly said, that means experienced people like you have been using thrombosuction over years, and you said you use it even in moderate thrombus burden because you know the importance of not stenting in a high thrombus burden patient. But contrary to the experience of people around, the evidence till so far of the use of thrombosection in acute STEMI has been a class 3 indication with a level of evidence A. And this came from the trials that started way back in 2008 that initially said, yes, the myocardial blush grade would improve. But subsequently, the TASTE trial in 2013 and in the total trial in 2015 said that even though the microvascular perfusion might be better, the myocardial blush grade might be better, but the clinical outcomes were not significantly different. And in fact, they raised a clear concern of stroke in patients at 30 days in the PCI alone group, with the use in the thrombectomy group as compared to the PCI alone group. But the same total trial marked a point that we need a lot of further innovation and research. So we moved from that era of manual thrombosuction with the use of the manual thrombosuction catheters that we use routinely in our cardiac cath lab to something that has really changed the outcome that I would be discussing. So this is the classical case in which we are really afraid of doing PCI, a very huge thrombus sitting right at the ostial LAD, like this case of 53-year-old male with acute hyperacute anterior wall MI and in a CLIP class 3 in pulmonary edema. And we always fear that thrombus migrating to the LCX and hampering the contractility of that viable territory. So in such a case, where we have a lot of fear of thrombus migration, comes the latest Penumbra Cat RX catheter and the evidence from the Cheetah trial that shows a very low distal embolization rate of just 0.75%. So we started with Penumbra thromboaspiration in this patient, and just you can see, just with one Cat RX thromboaspiration and a subsequent stenting without the use of predilatation, we could achieve a good TME3 flow in just 120 seconds and a total aspiration time of just 40 seconds. So this is a marked improvement over the conventional manual thrombosuction that we have been doing. This mechanical thrombosuction Cat RX shows a very low primary event endpoint rate of, and with a very low distal embolization. The freedom from MACE is 96.5% at 30 days. There is zero side effects, zero device related serious adverse events related to the use of this device, and an excellent TME3 flow and a myocardial blush grade. And as we means this catheter, it's the only drawback with this catheter is that we cannot use two wires simultaneously in a 6 French guide. If we want to use two wires along with this catheter, we have to use a 7 French guide, and it is not compatible with GuideLiner and GuideZilla as well. So another similar case, just to reflect the potential use of thrombus in ostial LAD cases. This was a post cardiac arrest patient resuscitated with CPR with a BP of 80 systolic and had a VF in our emergency. Post wire crossing, you can see the heavy thrombus burden that was still grade 4 to be precise in this case. And this classification of TIMI thrombus grade is extremely helpful. So whenever the large thrombus burden is more than 2 vessel diameters, that is grade 4, this is a very, very strong thrombus, very high grade thrombus, and especially in the anterior STEMI patients, this has excellent outcomes. Again, no use of pre-dilatation. The first cat-RX aspiration, thromboaspiration, the second cat-RX aspiration, and then you can see a marked reduction in the thrombus grade and absolutely no distal embolization. You see clearly delineated landing zones, and this is the time when you really need precision, and there's no thrombus to bother you at this time. And with this minimal thrombus burden, we used a larger diameter stent, we used higher NC balloon, we used higher pressures. So no matter what the situation is, we are very hesitant to use higher NC balloons, higher pressures in such cases. And without the fear of slow flow and distal embolization, you can see the excellent angiographic, and not just angiographic, not just TIMI3 flow, even the myocardial blush grade is pretty good. Another clinical area where I believe this device has a great importance are those patients, those who have high bleeding risk. And as the interventions are progressing, the HBR patients are increasing. Like this patient, a 46-year-old diabetic patient with dengue and a platelet count of 50,000. So I was apprehensive about using a lot of antiplatelets and anticoagulation. The patient was already on ventilator, KLIP class 4, a BP of 80 systolic, and this cat-RX thromboaspiration works great and immediately reduces the thrombus burden, and you can achieve a good TIMI3 flow even without very aggressive anticoagulants. Now let's take a look about the way imaging can kind of complement this technique. So this is a patient with acute STEMI equivalent, acute decompensated heart failure, a premature coronary artery disease patient, already underwent angioplasty to all the 3 vessels, but currently presented to us with a total occlusion of the left circumflex. So we changed that culprit vessel, and you can see how beautifully in this slide you can appreciate even in the distal LCX, you can see how beautifully this 5.3 French catheter has an excellent trackability, goes way beyond the stent that was placed in the distal left circumflex, and you have a gratifying result just after thrombosuction. You could achieve a good TIMI2 flow in this area. And then we did a OCT pullback to see the benefit, to see the underlying anatomy, to understand the pathobiology of that atheroma. You can document the instant neoatherosclerosis with the plaques rupture within that instant neoatherosclerosis, the residual fibroatheroma, the residual red and white thrombus. You can appreciate the intimal disruption and dissection in the upper figure. And then without the use of pre-dilatation, again I'll mention that without the use of pre-dilatation, took a stent directly, and this is the post-dilatation and the final result, a good TIMI3 flow. A similar case, again to document the excellent crossability of this catheter. In this case, I would mention that I had difficulty crossing a balloon. You can see the guide being pushed back by the balloon attempt, but the movement of the catheter just prior to balloon dilatation was pretty easy, even to the distal part. So just to impress about the good maneuverability of this device, and you can see again a very excellent TIMI3 flow in the distal vasculature. Another area where I see OCT or any other imaging for that sake complementing this technique is documenting the area of plaque rupture or the plaque erosion and kind of tailoring our therapy. Again, a 76-year-old male with acute inferior wall MI, a distal LCX occlusion. And after the thrombosuction attempts, we got a good distal flow post thrombectomy. You can see the reduction in the thrombus grade. And then we took an OCT, and we were surprised to see that the plaque rupture was not just distally, but even proximally in the proximal LCX with a good lipid pool, thin cap fibroatheroma, and even a plaque rupture in the proximal LCX that was being missed angiographically, and that needed to be covered. And you can appreciate the plaque cavity that gets emptied with this thrombosuction, and we completed this with a subsequent routine stenting strategy. So this is a summary, and as I said, we've used it even in rescue PTCA patients with high thrombus burden, in coronary anomalies, in tortuous vessels, even in distal vasculature. It has done great results, and this is the although it looks a similar way with the routine manual thrombosuction, but this mechanical thrombosuction is much larger thrombus aspiration in such cases. And we recommend a protocol which is known as the AVIS protocol. It starts with this mechanical thrombosuction followed by vasodilators, and then a good imaging run with the OCT preferably, and followed by stenting. And as I said, it has got enhanced deliverability, maximized clot removal. The quantity of clot is very high, and we've already witnessed the power of this aspiration in the stroke revascularization, peripheral vascularization, and now even in coronary vascularization. And immediately, the moment we start this power aspiration, we get a negative pressure of around 26 to 28 millimeters of mercury, as compared to a 30 cc syringe with the manual thrombosuction that gives a high negative pressure only for the first 2 or 3 seconds, and then the vacuum diminishes and the thrombus can get embolized, and hence possibly reflecting why the stroke rate was higher with the use of manual thromboaspiration. And this mechanical thromboaspiration might help us with a better TIMI flow grade. So this is the experience of the Cheetah trial, and this is our own experience, although limited to a few number of patients of 21 patients, that you can see the excellent thrombus debulking capability of this device. The thrombus grade reduces markedly, the MBG myocardial blush grade and the TIMI3 flow improves dramatically. You can see the change of color from green to, I would say, orange in the topmost, just to reflect how the scenario is changing with this. And there are absolutely no instances of slow flow at procedure completion. The debulking is in line with the Cheetah study, which is way higher than the earlier TAPAS, Total, and other trials of the manual thrombosection. And we recommend it in all cases of ACS with large thrombus burden, that is grade 3, 4, and 5 thrombus, and more specifically grade 4 and grade 5 thrombus. And this is the largest data so far in the Asia Pacific region. So I would just conclude my talk that the way the thrombus grades vanishes, it's kind of a triumphant dance, a very beautiful, graceful reduction in the end systolic volumes that we can witness, the improvement of EFs that we can witness, and especially with OCT intravascular vision, we might use greater diameter stents, use more stent optimization with lower thrombus burden, and especially in the STEMI script, I would say that this thrombosuction has a huge tail to unfold, that we can unfold ourselves in each and every individual patient, especially with intracoronary imaging. Thank you so much.
Dr. Shokar, you are here. Can we have a quick 1 minute some discussion?
I think I fully agree with Dr. Tanuja. We should use this in a very large thrombus burden, and especially a large vessel proximal, and where you think that is a large chunk of, say, TIMI 5 or 4 thrombus, where you expect a very high chance for a slow flow or no flow, even after the intervention, even after stenting. And definitely reduce the stent thrombosis rates, and as well as the distal flow at TMG grade also will improve with this, because distal embolization, even though it's reported frequently, that's a reason for made it as class 3 indication for routine aspiration. But we should individualize, and we should all large vessels, large thrombus burden, we should try to use this. I don't think any other way to solve this issue. Other option is to use the intracoronary lytic therapy. When you compare the intracoronary lytic therapy and thrombus aspiration with large thrombus burden, and thrombus aspiration is better. And if you use the penumbra-like device, definitely you'll get a good results. And I think it's no comparison with this, and this should be ideal. But routine thrombus aspiration should be discouraged. And when there is a thrombus burden less, and when the vessels are small, tortuous vessel, distal vessels, and we should not use. I think this is my view in this.
Yes, I completely agree. Please stay, because I want to show a small quick video about 5 minutes of Dr. Carlo Di Mario, which I took last year. So this is very important. I would, Dr. Shokar and Dr. both of you, please stay back. Dr. Carlo Di Mario is a very important cardiologist from United Kingdom, and now he's shifted to Italy. And I had he's a good friend of ours, and also attended a lot of meetings.
I am taking the advantage and privilege to be with Dr. Professor Carlo Di Mario, who is our friend and also collaborator for Indo-European Boards on Revascularization. So the purpose of this video is to give a small insight to the Indian population or the world population about how to prevent the heart disease. You see, this is too much. It's the number one killer of the whole population. The heart attacks in India, especially in Southeast Asia, is growing. With young people getting more affected, especially the males, but of course equally the females, with the stress going up. So there are 2-3 questions which I would like to take from the expert opinion. He's been a professor in Royal Brompton Hospital. Now he's working in Craighead Hospital in Florence, Italy. He is himself a legend because he has done a lot of research. He has been a pioneer in the stent studies, and then he did a lot of TAVI studies. I worked with Professor Alain Crepier in France. So number one, I would like to give you some insights about the prevention of heart disease, especially the coronary artery disease.
Well, I mean, this is an international congress, so definitely this is not the main aim of this conference. Having said that, there was yesterday a very interesting meeting on assessment of vulnerable plaque, and I think we are coming together with several recent investigations confirming that we can identify plaques at higher risk. Today is published in the Lancet the lipid-rich plaque trial showing an increase at 3 years that is double in the presence of a cholesterol content greater than 400 in a single position on a patient basis, and increases the risk from non-cholesterol rich to cholesterol rich plaque of almost 4 times. You may wonder whether this is sufficient to really this vulnerable plaque, higher risk plaque. However, I personally believe that this is one of the steps forward that will become part of our current practice. When we treat unstable angina patients, we currently focus only on the culprit artery. We scotomize all the rest. From now on, we have the possibility to look at remaining arteries, non-culprit lesion, and select patients that are at higher risk with, who may require more aggressive systemic and local treatment from patients at lower risk.
So how do you recognize these plaques actually? Can you, for the public, because there's people, simple people who do not know cardiology, how do they recognize? By angiography or CT coronary angiography or what?
Unfortunately, angiography is not enough. The particular study I was discussing is based on near-infrared spectroscopy, which is a technology not much diffused outside Japan, but there are other trials that are using optical coherence tomography, thickness of the fibrous cup, dimension, extension of the necrotic core, and other trials that consider presence of macrophages, and all of them somehow are adding small steps in the direction of detecting features of risk in a patient that angiographically may look all the same.
So this is in simple language, I may translate this for the general public. There are a lot of patients where you don't find a critical artery stenosis in angiography or CT coronary angiography, or treadmill test is negative. And these patients, you have many times you feel that the patient gets heart attack and we don't know what is the cause. So what he's talking about, the plaque, which is 20, 30, 40%, which is not critical, which is not causing obstruction, does not causing angina, the patient is fully hale and hearty, and these plaque rupture to lead to clot formation and acute heart attack. So now, from his study, he's doing very advanced heart studies. We will be able to identify those patients that whether they are high risk to get heart attack or not. This is for people to know. So other than that, just last question I would like to know from you. Of course, we know that smoking, diabetes, high blood pressure, high cholesterol levels, they are the high risk factors for prevention, and you have to control it. So from your horse's mouth, I would like to listen a little more about this prevention from the routine public.
Yeah, I would say rather than in this Congress has been the European Society of Cardiology Congress, where the new guidelines on treatments of lipid disease and the new consensus document with the Society of Atherosclerosis came up with extremely low thresholds now, especially for LDL cholesterol. Now we have been a progressive reduction from 100 in the past to 70. Currently the approved standard, but now in the last 2 months we should use 55.
So the LDL level should be as low as 55
with the current treatment, and of course requires a step up in what we are currently using, combination treatment, the highest activity statins like rosuvastatin and ezetimibe, and in the future more and more use of PCSK9 inhibitors. The introduction, as you know, of a new RNA-based drug that works with administration twice a year, achieving apparently, so it's very early stage, similar results as evolocumab and ilocumab, I think is extremely promising.
So this is very important. What he has told is, this is very important, that sometimes despite no smoking, despite control of diabetes, despite having a good cholesterol level, now we have come to the stage that not LDL level, which was considered to be 100 was okay, now has come to 70 and now 55. That means the reason why still these patients who do not apparently look like a high-risk patient, they still have the coronary artery disease, is because we are not controlling the LDL level to 55. And therefore, with a high combination of statins and other ezetimibe, as you said, should be given to all these things. Thank you very much, Dr. Professor Karnal on the World Heart Day. I congratulate everybody, especially the TCT, the organizers, Dr. Craig Stone, Dr. Martin Leon, and of course you have been doing lots of conferences. We hope to meet you soon in India, and we do Indo-European course on revascularization, which is to be held in Munich in the first week of May.
So I think Dr. Ashokan and Dr. Tanuj, Dr. Kundu, Dr. Akshay, thank you very much for this live session. Dr. Ashokan, we have had a good, fantastic first session. Of course, some glitches were there. One last thing which I would like to give a small token of advice to the interventional cardiologists, because this is also going YouTube live, this is a hybrid meeting, Facebook live, and people will see it again and again, that when I start a primary PCI and where you have clot burden, immediately after putting the wire, of course this is known to everybody, we don't do pre-dilatation. Thrombosuction first, then balloon. Of course, once you have seen that the thrombus has been removed, then do normal angioplasty and stenting. Thank you very much, Dr. Ashokan and Dr. Tanuj and Dr. Akshay. We go for a quick coffee break, only 10-15 minutes if we can manage, and come back with a talk of Dr. K.K. Kapoor in the next session, and Dr. Greg Stone, which will record a lecture, and Dr. Raj Dave recorded lecture. Ashutosh Marwa and Dr. Chavda will be the chairperson. So we can have quick coffee break. Just opposite, on the opposite side, we have a coffee. And but I would like everybody to come back within 10 to 15 minutes. Thank you.